And good afternoon, everyone. Welcome. I'm Joe Basha, your host of PerfWeb and your lecturer today. Welcome. This is PerfWeb 99, day 3. And this is our last day for PerfWeb 99. Still working on the PerfWeb 100. Want to do something really special. We'll get into that here in a minute. Let's go through this. Contact us at perfusioneducation.com. Contact at perfusioneducation.com. You want to send an email in to me, request something, you need help with something, you want to give a lecture, you want to ask a question, you want to be part of a panel, you want to come visit the studio, you want to do something, a program at your place, start a program of your own, please let me know, and we'll work through it together. I think it'd be a lot of fun. But anything you want to talk to me about, just call me up, reach out to me, and that's how you get a hold of me. Okay, our call-in number. If you happen to be driving and you want to call in after listening to all of this stuff today, our call-in number is right there on the screen, 832-239-5358. That's 832-239-5358. Okay. And there's our scroll bar. It comes up throughout the course of the program, and it's got all of our social media platforms on it, our call-in number, and that will pop up from time to time, and you can look at it. And it'd be great if you would subscribe to our YouTube channel, like us on the thumbs up, do the sharing, subscribe, do the FaceTime, the LinkedIn and the X, all of those social media platforms, whatever version of what you're supposed to do with those you're supposed to do. Would you please do those for me? Thank you. Next. Lean over a little bit. Oh, wrong way. Okay. Yeah, I'm hidden behind my app, the Critical Care app for perfusionists. It has everything on there from perfusion. It has ECMO. It has hemodynamics. It has conversions. It has an IV rate dose calculator, which is actually a separate app that you can get separate. It has a bunch of different stuff. You can do your quick calcs in the morning, get all the information about your case you need, your flows, your BSA, your predicted or your anticipated post-dilution crit, the whole thing. It's got everything in it. It's got stuff on ECMO. You can do DO2, DO2I, SVR, PVR. You can everything you could possibly think of. The big app, which has the IV rate dose calculator, is only $2.99. The standalone IV rate dose calculator is only 99 cents. That was pretty cheap. You could buy these for people for Christmas presents, birthday presents, graduation presents, whatever it is. Would love for you to it's $2.99, and it's a great app. For that money, that app is worth probably $29.99 at the very least. So you're getting a real bargain. At some point in time, we will increase the price. And when we do updates are included, and we have done updates pretty routinely over the course of time. So get our app. Next. Our podcast. You can go to whatever is your favorite podcast streaming platform and type in PerfWeb, and we'll pop up. There you go. It's easy. Our adult ECMO specialist training course. This course, I'm very proud of this course. This course is directed by Vicky Carlisle. It is also who's a ELSO certified adult ECMO specialist, as well as a CCRN, really just a brilliant person, very clinically capable, incredible skills and knowledge, and does a great job at this teaching. I'm part of the faculty with it as well, and it's approved for perfusion credits, physician credits, and nursing credits. So, and also advanced practice. So PAs, NPs, all the APPs, perfusion, everybody on your team. And it's exceptional training. 2 days of didactic, and you can do the didactic only if you choose to, or you can do, and that's coming up in June, or you can do the full course, which is the 2 days of didactic, 2 days of simulation, wet lab, and it's here in Houston at Memorial Hermann, the Woodlands, in their really incredible conference center. It's really, really nice. Yeah, you can't go wrong. And Houston, especially in the Woodlands area where we are, has so much to do. It's 2 days. Thursday, Friday is the didactic. Come out here Saturday, Sunday, enjoy yourself. Monday, Tuesday, do the simulations. The Intercontinental Airport's very convenient. Go home Tuesday night. You're back in your bed for some sleep before work Wednesday morning, or take an extra day, whichever you prefer. Okay, that's it. Okay, so we're done with our opening remarks, and welcome everybody. Today's program is going to be a hybrid. I'm going to do a lecture first, and that's going to take about 45 minutes, maybe an hour, in that range. And then we're going to do some simulations. And we can show you a real quick, I think, overview. But we have an ECMO circuit. We have a CRRT machine. And we're going to learn about how these pressures work, one, independently. And then we're going to learn how these pressures work when they're connected to each other. Because it's very frequent to see CRRT used on ECMO patients. And you don't want to, especially somebody who's anticoagulated, you don't want to have to stick another line in the patient and possibly have a mishap when you have access right there in the CRRT machine. But a lot of people have problems doing it. And there's reasons for that. And there's ways to do it that work, and there's ways to do it that won't work. And we do it all the time. We have, I think, a good way to do it, but we're going to explore some of the various different ways and why one may work better than the other, and how all of these pressures interact with each other when you're on ECMO and CRRT, with the CRRT machine integrated into the ECMO circuit. Okay, we'll go ahead and start my slides. If anybody has any questions, wants to call in, don't forget we had our call-in number. I set it out to you. You're welcome to call in and be a part of discussion today. So I have no disclosures or anything like that. CRRT stands for continuous renal replacement therapy, but CRRT, ultrafiltration, hemofiltration, modified ultrafiltration, sustained or slow continuous ultrafiltration, CVVH, CVVHD, CVVHDF is all designed to help to reset or maintain either total or some portion of homeostasis. It is an umbrella term, CRRT that is, to describe a variety of therapeutic modalities, of which I just listed off, used to treat renal insufficiency is one, and these are all mutually exclusive. And that's something I want to make sure that I stress. So used to treat renal insufficiency, 1, fluid overload, 2, electrolyte and acid-base disturbances, 3, removal of metabolites, 4, and to some degree, removal of inflammatory mediators. Now, it can do all of those things simultaneously, or you're only doing it for one thing or another. If you have renal insufficiency, and you're going to frequently have fluid overload, electrolyte and acid-base disorders, so you're going to be using CRRT in that setting. But you don't have to have renal insufficiency to have fluid overload, electrolyte disturbances, and acid-base disturbances. That can be for a very different reason, cardiogenic shock being one of them. And this is very good for the treatment of that too. I'll discuss a little bit more about my view on the underutilization of CRRT. So here is a curve that shows the clearance in percentage of various different size molecules. And you've got urea, creatinine, potassium is down in this level, sodium's around this level, everything pretty small. And the clearance of these small molecules is very, very, very high with dialysis, right? That's what we're talking about here. The kidney, on the other hand, removes all of this. And what we are endeavoring to fill in terms of a gap is this area in between, shown here. So if you have various different inflammatory mediators in the, let's say, 20,000 Dalton range, your kidney is going to be able to clear those fairly readily. But if you're doing dialysis, it is not going to be able to clear that. In fact, it's not going to clear it at all. With dialysis, meaning you're doing diffusion clearance, by the time you get past about what it looks like about 5,000 KD or 5,000, 5 KD or 50 KD or 5,000 Daltons, that's right, in size, you're only removing at about 40%. So much, much, much lower. We need something that is going to work a lot better than that in removing it at a higher level and farther out. And that's what we're trying to accomplish here. So this paper that was written, and it was written in 2000, I would recommend to anyone that you go out and find this article. It's very easy to find. It's online. You don't even have to pay for it. But this article is what began my CRRT journey, if you will. And it's amazing to me that this article was written back in 2000. This is 2024. I started sort of dabbling in the CRRT arena around 2003, much to my surprise, with tremendous pushback from a lot of people, especially nephrology, which I found interesting. And there was quite a bit of controversy around it, which didn't baffled me to some degree, because nephrology did not want to do it. They saw it as something that was bad. And, Z-Buff on pump from way before this and how well it worked. So there was an intuitive nature to use CRRT in patients who had severe acid-base at a state hospital. It was a charity hospital in Louisiana, and she was 28 liters fluid overloaded. 20 use of CRRT. Now, I didn't have a fancy CRRT machine like we have today. I just used a couple of freestanding roller pumps and created my own. I didn't have fluid that I could buy, which is very easy to do. Remember my talk from yesterday. So it was a real challenge, but we were able to help her, and she did survive. So this guy here, probably one of the most fascinating guys I've ever had a chance to say hello to. I that's about as far as I've gotten. His name is Claudio Ronco. He's who wrote that article, and he's in Vicenza, Italy. And the dude is absolutely brilliant. He speaks 4, 5, 6 different languages. He's a nephrologist, intensive care medicine doc. Just super, super smart and knows a lot about this. So if you just look up this article and then find other articles written by Claudio Ronco and Ronaldo Bellomo, who I don't mean to understate his importance to all of this. And he's from Australia, and he's also very, very, very well respected and knowledgeable in the field of. We call it renal replacement therapy, and that's what's wrong with CRRT. Is you call it CRRT, the name. That's what's wrong with it. Really, I prefer to call it CVVH or Z-Buff or CVVH-DF, whatever you want to call it. But I don't like to use the term CRRT because I think that implies it's dialysis. And it can be used as dialysis, but it's not dialysis. It's really Z-Buff. But in this study that I had read, they took patients who were critically ill and they used different doses on these patients. So however much effluent you're taking from the patient is removing plasma water. So it's basically the same as Z-buff. And when you replace that fluid with something else, then the effluent rate, which has to be replaced 1-to-1 for it to work properly without removing too much volume from the patient. And you can take extra, but what you take, you're supposed to give back. And if you're running it low at 20 mLs per kilogram per hour, or 35 milliliters of replacement fluid per kilogram per hour versus 45. These are the 3 patient categories they did. And it was a relatively small study. I mean, I granted that. But their results were really remarkable. Here's the basically the patient population that was done. Sepsis was very big in this patient population. But this was the slide, I think, that said it all. Group 1 had a survival much, much lower than Group 2, which was the 35 milliliters per kilo per hour. And Group 3 had a, not statistically, but somewhat higher survival than patients that were in Group 2 and obviously in Group 1 as well. And so I knew from the beginning that underdosing was not the way to go, that using high volume zero balance ultrafiltration, or CVVH, continuous veno-veno hemofiltration, is definitely the way to go. And that's one of the problems that you will experience in your practices with nephrology, which, you know, again, nephrologists are probably the smartest people in the hospital, be frank with you, but they're caught up on something, and I don't understand what it is, but they really underdose not infrequently. I don't know if any of you have that experience, but if you do, please let me know if you also see that in your practices. So we discussed this. What is it used for? Acute renal failure, acute fluid overload, metabolic derangements, acid-base derangements, inflammatory mediator attenuation, creating a physiological environment to relieve the stress from the body's systems. So if you have someone who is massively fluid overloaded, their heart's distended, they're edematous, they have scleral edema, their earlobes look like water balloons, and you got to get that volume out of those patients. And as you're removing that volume, you have to make sure that you have a plasma refill rate that is appropriate, and you may have to treat with albumin in order to get that fluid back from the interstitium, because when you see that kind of edema, all the organs are that edematous too. You just can't see them because they're inside. So you want to get those organs back to normal water volume inside the tissue in order for them to function properly. And you see these people get remarkably better because you can use this for fluid removal, much in the same way we do on bypass when we do standard ultrafiltration for fluid management, whether it be cardioplegia, del nido, whether it be our prime, whether it be poor, it doesn't matter, irrigation, whatever it is. When we have excess volume, we want to get it out. We don't need it, and the patients do better. There's a tremendous amount of data out there that drier patients do better, not desiccated patients. So I don't want to be misinterpreted. I do not advocate for removing volume from a patient that doesn't have volume that needs to be removed. You remove volume as it is needed to be when the patient has more excess water in their bodies. That's what you want to remove. Not blood, not plasma, but the plasma water, which will be in excess. So there's 3 basic ways that CVVH works. There's 4. Ultrafiltration, and I'll talk about that. There's diffusive clearance. So ultrafiltration, and we'll talk about it a little more, is isoosmotic. I think we discussed that a little further. If I don't, I'll come back to it. Diffusive clearance is what you get from standard intermittent dialysis. And then there is convective clearance, which can only be done if you are using CVVH or you're doing Z-buff. That is a convective clearance, not a diffusive clearance. And we'll discuss a little bit how those mechanisms work. So here you see a solute getting poured in over here. You've got a semi-permeable membrane. It wants to be balanced, so it will go through the membrane, and now you have the same on one side versus the other. That's basically diffusion. We all are familiar with that, so I don't want to belabor the point. Ultrafiltration is when you are using pressure, either a positive pressure on the blood side, which is what you're seeing here, or a negative pressure on the effluent side, which you see here, will pull water or push or pull the water across the semi-permeable membrane. So you can have more volume in this column than you have in this column. But you must remember that all of the solutes in here will be exactly the same as they are in here, because this is isoosmotic. Now, convection is what you get when you use a thing called solvent drag. And that is, as you're applying either a negative pressure on this side or a positive pressure on this side, positive, negative, you are pulling water across the membrane in basically, we'll call it clumps for the sake of this discussion. And whatever is dissolved in that gets pulled along with it. So as you're pulling the fluid across, you will see that the concentration of these ions will be higher on this side than on this side, even though you have literally removed water from this side and put it into this side. And I hope that made sense to everybody. It made sense to me, but I just want to be absolutely sure. So this is not an example of isoosmotic. This is removing solutes that are dissolved in fluid, and because you're pulling it or pushing it across the membrane, you will remove a higher concentration and leave a lower concentration as well as less volume on this blood phase. Okay. So here we see another example of that, semi-permeable membrane in the middle, and you've got a high concentration here. You have over here something that doesn't have it, whatever it is, in it. And as long as it's big enough to freely go across the membrane, diffuse across the membrane of the hemoconcentrator, it will. But this is restricted to very relatively small solutes, very small, okay? That's the difference. Here, what you get is these clumps, as I said, of water coming across in a much larger, with a force against it, which allows for much larger solutes to be forced through with the water that's being shoved through the pore or pulled through the pore into the effluent side. So that's why it's not green, because there's no dialysate in here. This is standard ultrafiltration, just like we do on bypass every day, if you use it every day. I use it every day. So here is what I was talking about earlier. Excuse me one second. I'm so sorry. Let me turn the volume off. So here you have, and we talked about this yesterday. If anybody can answer the question today, you'll win a prize. If you notice, the axis is red. The flow is coming from the patient, going this way through the pump into the filter, out of the filter, and back into the patient. Why is the return line blue? and the access line red, because we're perfusionists. We turn blue blood red, right? So there's a difference. Why is that? You'll also, while you're thinking about that, over here, volume X, whatever you want it to be, you pull off your ultrafiltrate. It's in your waste container, whether you use a Neptune or you use a suction canister, whatever it is you choose to use to collect your ultrafiltrate. And your sodium's 140, K is 5.2, chloride's 104. Albumin, total protein, and hematocrit are all 0 because their albumin is 65 KD or 65,000 Daltons. It's too big to go across a hemoconcentrator. So you have to have a very different type of filter in order to remove the blood plasma and treat that separately. But point I'm trying to make is, you see over here, there's no change. The patient's sodium, potassium, and chloride will not change at all. Now, your albumin level, your total protein level, and your hematocrit will all increase because you're removing water volume, which is dilutional to these things. And your total blood volume will go down. So you have to know you have the volume. You can afford to remove the volume. You can't remove volume that's not there. You can, but that's harmful. I completely agree with that. But used correctly, you can really help yourself not having to transfuse your patients and control bleeding, because theoretically, if I came off bypass with these numbers that you see over here, albumin, protein, and hematocrit, and I still had a liter in my pump I can't get into the patient that I'm going to send over to the cell saver, you'll get the red cells, but you're not going to get the albumin and the total protein. So I would rather hemoconcentrate that. And there was this guy, Keith Smolik. I don't know how many people know of Keith, but he's the guy that invented the hemo bag. Now, with all due respect, I thought the hemo bag idea was, it didn't make any sense to me. It was a good idea, but I could just do it on the pump, just hemoconcentrate everything in my venous reservoir until I'm down to nothing. And then I can chase that all back into the patient. I don't have to give them as much volume. But I think that's a much better idea than to send everything to the cell saver and have 3 or 4 units of cell saver blood to give back to the patient, because you lose all your albumin, all your plasma proteins, your clotting factors, and your platelets. And you're giving red blood cells back in a saline base. That's good, but if you need the other stuff too, it's bad, right? So that's my view on that. And then the fourth one from that list, remember I said 3, well, it's really 4, is adsorption. So there are a not insignificant number of inflammatory mediators that are too big for even a hemoconcentrator or CVVH. And how you can clear those with the use of CVVH is through adsorption. And what that means is, and I think we all know what adsorption is, it's an adhesion type of process where if you have the right charged filter for the evil humor, if you don't mind my using that term, that you're trying to remove, then it will stick to the surface of the membrane, the semi-permeable membrane, and that's referred to as adsorption. And your filters will clog, not clot, clog, because all the pores will get clogged with these things that you're trying to remove. And as they do, your filter will fail, and then you have to change it. But you do that a few times, and then you don't have to do it as often once you get good clearance. Now, there is, of course, the other option, which I think probably makes more sense, is to use the CytoSorb whole blood plasma filtration system for removing these inflammatory mediators that are just too big for CVVH to accommodate. But CVVH does really well with TNF alpha, with several of the interleukins. It's a very good technique. So now let's take a look at some of the various different ways that we can integrate the CRRT circuit into our perfusion circuit. So let's just follow this down, drainage limb from the patient going into our centrifugal pump, leaving the centrifugal pump and going into the oxygenator, turning blue blood red. Oh, I forgot to tell you the answer. Did anybody get it? No. Okay, so I'm going to go back. So right here, this is diluted blood, and this is concentrated blood. We all have seen it when we're in the OR, and we've got a patient with a higher crit than what we're used to. We're looking at the line and wondering, is our PO2 okay? And our PO2 is 300 or 400. If you have a PO2 of 300 or 400, that's going to be 100%. And your hematocrit is 18 versus that same exact patient, same exact blood, same exact PO2, but the hematocrit is 27, it will appear much, much darker. That's why in the dialysis world, access is red, return is blue. That was very challenging for me to get used to, I will tell you. Okay. So here we are back in our system. Blue blood in, red blood out, back to the patient. Now here's our CRRT machine right here. And in this configuration, they have attached, remember, red is access, the access post-pump pre-oxygenator. It's going up into the hemofilter, out, and it is returning to the negative side of the circuit. Now, this is a technique that I think works well. I don't choose pre-oxygenator because that is the point of highest resistance in my circuit. So I go someplace else, and we're going to discuss that. And I'm going to show you that and show you all these different places you can put it and why one works versus the other. But what is very important, and I'm going to show you this, is every hemoconcentrator, hemofilter, whatever it is, in order for there to be a fluid removal component to it, has to have an adequate transmembrane pressure, otherwise known as TMP. Okay? So if I'm on bypass and I'm using, or I'm on ECMO in this case, we're on ECMO, I'm sorry. I know that this line right here is going to be a negative pressure. This is going to be a negative 100. It's going to use a number arbitrarily, okay? And as this ultrafiltrate is connected, now it has a pump, but it's connected to the outside of those fibers. So the blood goes through the central portion of the straws, and then the plasma water or effluent goes out to the outside of those. And this is under negative pressure. It is going to be pulling the plasma water back into the straws, or it's going to be resisting the water leaving. And this pump is going to have to turn faster and faster and faster in order to get the same volume that you wanted to get out. So what I advocate is you always want your TMP to be positive, number one, and I prefer for it to be positive enough that this pump, instead of pulling water across the hollow fibers, is acting as a dam, controlling how much plasma water is being put into the effluent waste container. So that's my preference, and we'll show you how that works. Whereas if you were using this configuration, here, now you see a completely different configuration. Still have turning blue blood red, CRRT machine right here. Okay. My access is red. It's post pump, pre-oxygenator coming up, going through this pump into the hemofilter and out. And now it too is going to the positive side of the circuit. So post pump, pre-oxygenator, and this return pressure is no longer going to be negative. It's going to be very positive, very, very positive, which can create its own set of problems. And one of those problems that I'll be able to show you on device, each device is different. I don't have a dog in the hunt with the devices at all in regards to relationships with the companies. I will tell you that I dislike all of the companies in that market equally, whether it be Baxter Gambro, whether it be Next Stage, whether it be Braun. As far as I'm concerned, they're all the same. However, in terms of a widget, in terms of a device that I think works the best, whether it be in the ECMO world or the non-world, just in the critical care unit with critically ill patients requiring it, in my professional opinion, the PrismaFlex and the PrisMax, which is Baxter Gambro, used to just be Gambro, is the best tool that I've had the occasion to use. That is my opinion about that, and there's reasons for it. One of the most important reasons is it's gravimetric. There's scales that weigh all of the fluid, and if the pump is turning to remove, we'll just say, one liter over whatever period of time, and that scale, that bag in that scale doesn't see that 1 liter weight change, whether it be up or down, it will fail. It will alarm. It's going to let you know there's something wrong. So I think that's one of the most significant things that make that particular device a much better tool in my book in terms of safety for patients. And effectiveness of therapy, accuracy of therapy maybe would be a better term. So, but with that said, what I have noticed happen is my return pressure pod, which is somewhere in this area, I'll show you on that particular machine. It's going to be somewhere around here going up to a deaeration chamber. The high pressure of this pump is going to push that up and up and up, and eventually it gets into the line where the transducer is, and it will ruin the circuit, so you then have to change it. If you have it on the negative side, you'll see it go down, 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 and you can actually entrain air. But we're going to look at that as we move forward with this, because I want to show you those are things it's very hard to draw something like that or explain it. So much easier to see it. And we have a really cool, I think, demonstration set up for you today. So I think you're really going to enjoy it. Okay, moving on from there. Here you have same setup, turning blue blood red. CRRT machine is here. In this configuration, we have the access coming off of the patient limb of the return line. So whether that be the femoral artery, whether it be aorta, central cannulation, or whether it be the return limb on your Crescent or Avalon catheter if you're doing just VV. So it could be anything, but it's your return line, your arterialized return line going back to the patient. Comes in, goes down this way, comes up, and boom, goes into the drainage limb on the negative side. So remember, this is very negative. This is going to be about minus 100, maybe even more, depending on the size of your cannula and how much your flow. And if your return pressure line is here going to your deaeration chamber here, it's going to pull the volume lower and lower and lower and lower, and that you possibly could entrain air. And when you do, it's almost impossible to get these machines started. You do not want to get air in your circuit. It's really bad. It's really frustrating. And so here we have blue blood red, same thing, hemoconcentrator. Our access is red, and it's coming off of the outlet port, either a recirculation line, which is how we do it, or a purge line of some sort out of the oxygenator, coming up, going in, and then returning back pre-filter, okay, or pre-oxygenator, I'm so sorry, coming back here. Again, you can do it this way, not how I like to do it, because I think you get a lot of alarms this way, but it can be done, and there's ways to overcome all of those things. The other thing I wanted to talk about is that each of these methods that I just talked to you about, where the access is distal to your return, just like in this setting, you will have some increased recirculation, right? But with that said, remember, your ECMO flow is probably going to be 4 to 5 liters per minute, and your CRRT flow, hopefully your guys run it a little bit better than what I've seen. I've seen 200. I much prefer 300, and I love it when it's at 400 because you're treating more and more of the patient's blood volume, and you have unlimited access. So there's no really reason to run your blood flow rate so low, but you're still at 300, well below 10% of your total ECMO flow. So how much of that really gets just recirculated back? It's probably some portion of it, but it's not a lot because you're blowing by it so fast. But that is a consideration and a concern, because recirculation, that's bad when you're talking about VV ECMO. But in this particular thing, because the flow differentials are so great, I don't really see it as an issue. Here we see the access coming from the pre-pump. So access is negative. That's going to be a real challenge. I do not advocate this. Going in and then returning to the positive side. You can do it this way, but I wouldn't do it. And that's it for these different slides. So now we're going to get a chance to actually go over there, set flows, set pressures, and try the different locations and see what it does to the pressures in the CRRT machine and in the ECMO itself. So most of what's going to be affected is going to be your CRRT machine. CRRT machine is really not going to have a whole lot of effect on your ECMO, other than if you're taking 300 cc's a minute from it, and your flow probe is proximal to wherever your access is, then you may have a little less flow than you thought. So my solution to that is always make sure that your flow probe is distal to anything that you're putting in or taking out of your circuit, because that tells you what you're actually delivering to the patient, right? Makes sense. All right, good. Let's do that. Let's go over there. All right. Shiraz. Hi, Shiraz. Kelvin, good to see you. Michael, Ahmad, Derek. How's everybody? I hope everybody's doing well. It's almost Friday. I hope nobody's on call. I hope nobody's on call that's on the program today. But if you get any of the questions right, I can arrange for you to get extra call and a type 1 dissection, just in case. And you get a goat. I got a new goat. Vicky, if you're watching, there you go. All right. All right, so we have worked really hard to put together this circuit, maybe down a little bit more. Zoom out just a little, maybe. Perfect. Nope, zoom in a little. That was a little too much. Right there. That's perfect. I like it. Perfect. Can't ask for better than that. So we have basically our circuit here, and this is not an ECMO course per se. This is truly about connecting a CRRT machine that you see over here that's on the right side of your screen to the ECMO circuit that you see here. And I'm going to kind of go through this circuit with you and what we're doing. And then you have your actual ECMO device over here. But, you know, we have cameras on it, like here with the flow probe. My hand will go there. You'll see it. And down here where our pressures are. So first thing I'm going to do is purge some of the air out of this thing. It's been sitting here running around in circles for a while. So there you go. Okay, everybody's used to hearing that noise, I'm sure. Okay, there we go. All right, there, we're de-aired. Okay, so the first thing I want to do is go over here to this CRRT machine. Now, you may not see, let me get out of the way. Yeah, please. That'll be good. Thank you. I can? No, this works because they can see me here. I like this. Okay. So what you're looking at here is a CRRT machine that I have hooked up to just an IV bag with some clamps on it to create the appropriate resistances that you can work with. But you see our blood flow is at 200. Our pre-blood pump is not running. Our replacement isn't running. Patient, nothing else is running. So I'm just running right now blood flow. That's it. And I want you to look over here. Our access pressure is negative 87. Filter pressure is 144. Effluent is 91. That's positive. And return is 87. So let's go through all of these various pressures and what they mean. And I will tell you that if I change any of these things, it is going to have an effect over here as well. But one has to remember that, are we on camera? Am I on camera one? Yeah. One has to remember that CRRT not hooked into your ECMO circuit is hooked into a temporary dialysis catheter. It's a double lumen catheter. We're all very familiar with them. There's Maherkers, there's Quintins, there's probably others. Those are the two that I know. And basically, you get one's red, one's blue, and you have access and you have return. And they're usually about 11 French in size. Your return size is smaller. The access size is larger, and that's the same with the crescent cannulas or any double lumen cannula because there's always more resistance to access than there is to return. So you're looking at a pretty small 11 French catheter that has two channels in it, one for access, one for return. And the machine is designed to operate in that environment. So it expects for there to be resistance to access in the red, and it expects for there to be resistance in the return, meaning the blue, right? So that's why in this particular setting, these are the numbers that you would expect to see: a negative 8990 access and a return pressure of 94. Now, your filter pressure is the pressure which is being read right here. So let's just go through the circuit if I can. You have, and it's like I said, it's hooked up to our simulated patients. So you should be able to see this. Red is access right here. Can I see it? I don't know. I'm too high or too low? There. Let me go on the other side. Closer to the machine. Okay. There. Okay. Red is access right here. Okay. Coming from the patient. The blue is going to be the return going back to the patient. So if we follow the circuit, it comes up and you see a pressure pod right here. This pressure pod is your access pressure. That's where it's measuring it. It's before the roller pump that's going around. So it's pulling through the catheter, through the pressure pod, through the roller pump. Then it leaves and it goes into this pressure pod. This pressure pod is your filter pressure because it is post-pump, but it is before where your filter is. So that is going to be your filter pressure. That's going to be the point of highest resistance, because after that, you have your pressure pod here, where this is your deaeration chamber. This is your return pressure, and you see your return pressure is 90. That's going to give you a delta P of about 50, 60, somewhere in that range. So that's how much resistance is in this particular filter, because right now I just have water in it, so there's really no other reason for that pressure to be different other than the natural resistance through this. So this pressure is always going to be higher than this pressure here. Now, if you look here, this line is yellow. This pump here is your effluent pump. As this pump turns, it's either controlling the volume that's being forced through this filter, or it's trying to suck it across, again, which I can show you why that's a problem. I'm going to try to illustrate that here with you today, but we'll do that towards the end because that's a little bit more challenging. But nevertheless, your effluent pressure is measured here in this effluent pressure pod that you see right there, and that's reflected in this pressure, your effluent pressure. Okay, this is a very good number to have. Now, click this button here, and this is your TMP, your transmembrane pressure. So it's currently running positive, but it's a 5 to 579, and your pressure drop is 30. But I can increase that transmembrane pressure by either increasing resistance to the outflow or increasing my flow rate and not changing the resistance in my outflow, because if I increase the flow, it's going to automatically, of course, increase the pressure, right? That all makes sense. So let's just do that for the sake of this discussion. I'm going to go to adjust. I'm going to go to blood flow, click blood, turn it to 300, confirm. It's going to take a second. It's going to go up. You're going to see that your access will become more negative from where it was. Now look at your filter pressure and your return pressure. Your effluent pressure is much, much higher. And your TMP jumped up to 18, 19. So you see how just increasing the blood flow had an effect. Now, right now, all I'm doing is spinning blood, right? That's all I'm doing. But let's say I decided I wanted to remove fluid, because right now that fluid's going to freely cross that filter, but this pump is blocking it. So if I go here and I want to do patient fluid removal, and I'm going to set it at, how about we do something fairly dramatic? We want to take a lot of volume off this patient in a hurry. I'm going to set it to 500 cc's in an hour. This pump is going to turn on. Now let's go back and look at those pressures as that happens. Watch your effluent pressure. I might have wanted to go a little faster. Let's try a little faster. Let's go to patient fluid removal. Let's set it at, instead, how about 1500? Now let's watch. You see the pump is turning faster, and you see your effluent pressure is coming down, and your TMP has gone up, your transmembrane pressure, because the pressure on the blood phase didn't change, but the pressure on the effluent side did, increasing that gap or that transmembrane pressure. That's why that happened. So this is how the configuration would be, and I don't want to run out of prime in my simulated patient and run them empty. So I'm going to come over here and put that patient fluid removal back to 0. And remember, this lecture is not about how to run CRRT. It's about understanding how the pressures interact, one, with the machine in a standard configuration, but more importantly, how it interacts when it's connected to an ECMO circuit. So I'm going to pause this as if we would connect it to the ECMO, and I'm going to bring the lines over there and show you a way that we do it and what will happen with this when I do. So look at those numbers, try to remember those numbers, and let's see what's going to happen. Okay? I'm going to pause this. Okay. Magic, I might need your help a little bit. Okay. Okey-doke. All right. So let me bring these over here. Okay. So before I do that, let's go over this ECMO circuit. Okay. Give me to about 3.5 liters. That'll be good. Okay. All right. So hello, everyone. There you are. So here we have our ECMO circuit. And so I want you guys not to focus on me, but focus on this camera here, the one that's pointing down. Here is our line coming from the patient, okay, here. And so, sorry, this is our blue line. What's it say? Yes, I know that. Okay. So this is our access, our blue line. It's coming down into our centrifugal pump here, out of our pump, into our oxygenator here, out of our oxygenator here, going through our flow probe here, going through our pressure line here, and then returning back to the patient. So that's our basic ECMO circuit, all right? I'm measuring the return line pressure, which if you look in the center column is right now 100. It's P1. That's this pressure that I'm touching right here, which is our return line. Our access pressure is being read right here in our access line, and this is P2. You see that it's negative 105. As I told you, red is access in the CRRT dialysis world. And in our practice, what we do is we connect it to what is a recirculation line that we use. So I'm going to show you how we do it, and then we can talk about some of the other ways that we do it. So that gets connected there. I turn this stopcock 180 degrees so that it is open both this direction and it is open to the CRRT. And then I go ahead and pop this open here. I take my return, which is blue, and I connect that to the next stopcock down in the circuit. Now, normally what I would do is I would have an IV fluid or blood administration line on this stopcock here, which I could also turn and do all these things simultaneously without having to interrupt any of the therapy. So I'm going to turn this stopcock 180 degrees. Okay? Now, I haven't even started anything over there. So we're going to start it, and we're going to see what it looks like. So Magic, if you would be so kind as to go ahead and hit either continue or whatever the option is. Yes. Mm-hmm. What's it say? Resume. Yes, please. All right. Now, you saw that blood flow, And if you remember, our flow was minus 100 in this line, and it was positive 100 in the return line. So we got a drop in both of them off of losing, because we're, I think, at 3.5. We were at 3.5 liters. But now we're down to 3.36 liters because we are stealing some of that flow, even though it's coming back to that machine there, and it's affected our numbers on the ECMO circuit. And I'm going to just take this for giggles, if you don't mind. And because we're going to mess with this, and I'm going to move this flow probe a little bit further down to right here. Okay, there we go. Make sure we put it in the right way. There you go. Okay, now it's past where we measure the pressure in the circuit from. So now you see, so what are our pressures there? I can't really see them. I have to come. Oh, there you go. Thank you so much. Now look at how low our access is. Now, why is that? You're thinking, but you're on the positive side of the pump. Why didn't it blow up? Look at your effluent. Look at your return. It's also positive. And the reason that happened, and take a look at the TMP. Go ahead and leave that, tap TMP. It's back down to 5.7. It was up to 20. Now, if I decide to increase my fluid removal, so to hit adjust. No, that's not adjust. Yes. There you adjust, yeah. And go to patient fluid removal, bottom right. Turn that up to 1500. Just push and hold. It'll go faster. Good. That's close enough for government work. Confirm all. Now let's watch what happens to the TMP. Your TMP is going up, and your effluent pressure is coming down. And that's because that pump is trying to now pull that volume across. We can improve that a little bit, and I can show you that too. So stop the patient fluid removal for a second. No, not stop. Resume. Okay, adjust. Patient fluid removal. Hold the button until it gets to 0. Just be patient. It'll go fast. Very good. Confirm all. Good. Now, I'm going to do a simple thing. All I'm going to do is I'm going to turn this stopcock. Remember, blue is access. I'm going to turn this off to the recirculation line. So it's going to be coming this way and going directly instead into this access here. I'm sorry, here. Wrong side. Access is red. So watch those pressures. Put that CRRT up high. There you go. Watch this. Look at that. See the access pressure go up? Warning, return disconnected. What happened was it believed, because we changed those pressures so rapidly, that it had become disconnected from the catheter, because the device is made to run on a catheter, not a circuit. So what's it saying? So hit continue, please. Very good. Now, let's go back to our ECMO. Good. So now look at our pressures with that flow. And that's because I took that recirculation line away. That recirculation line is no longer going this way. Now, this is reflected off of just this. This is reflected just off of this. Does that make sense? Now, watch this. Just hit continue. Override, continue, whatever. Okay. Now, bring that up tight again. Yes. Now, what I want you to do is go up to, before you do, I need somebody to answer this question. And look at your effluent pressure. Your effluent pressure is now negative. That is bad. And I'm going to show you why. Let's go to the full screen. Stay right there because I'm going to need you anyway. Go to the full screen. Look at how low this deaeration chamber has gotten. Can you see it? You can't come down here, can you? Right there. Look at how low it got. It was up here. Because the effluent pressure is negative, it's pulling across the membrane and it interacts with this blood here, pulling all this direction in order to get the effluent out through this area here. So you have to be very careful of that because this is now seeing a negative pressure in your return. Your return is minus 53. It's literally pulling across. Does that make sense? So let's go ahead and just hit override, please. Okay. Now, what happens if I reopen that? So let's do that. Watch your pressures. Go to the full screen. Now watch your return pressure. Your return pressure is going to go back to being positive, which is what you want. Hit continue. It'll do that because it sees a big difference all of a sudden in your, just keep hitting continue. Thank you. Okay. And here on my return, that's access. So go back to full screen on that. I'm going to now take this line on the return and I'm going to turn it this way. Okay. So now I am negative pressure on my return. Go ahead and keep that big. Look at how low that return pressure is getting. But my access pressure is still positive because I'm further downstream. Okay? So let's go ahead and pause it. Stop. You did it? Yeah. Okay. Okay. Now, I'm going to hook the access up to this line before so this is your return, your line coming out of the pump going into the oxygenator. Okay. That's your access, and I'm going to leave the return here. Haven't changed any of the settings. Go ahead and turn it on. Resume. And let's watch and see what the pressures do. So again, your return pressure is very negative, and that is not good. I cannot stress that enough. You do not want to see that. So how am I going to fix that? How I would fix that, but your access pressure, go ahead and just hit continue, please. And can you keep that up big? Thanks. Look at how high your access pressure is, much, much higher than it was. Your effluent pressure, your return pressure, both are very, very low. They're very negative, and that's not good. Now, if I were to partially occlude this stopcock by just turning it at a little 45-degree angle, can you keep the PrismaFlex big? Thanks. Okay. Yep, I went a little too far. Just hit continue. Just give it a second. Okay. Oh, hit release clamp. Hit release clamp. There. Okay. Turn it back on. Thank you. Okay. I went a little too far, and that's the difficulty with finagling with this. So I'm creating some back resistance because I want the return pressure and the effluent pressure to be positive. There you go. And just that turn on my stopcock. No, could you? Oh, I see what you're doing. Yes, because you can't see it. Little turn on the stopcock. Look at how much better those pressures are. Both your return pressure and your effluent are both positive. That is ideal. And if you look here, you see that that actually came up just a little bit. Other view? You can see that this came up just a little bit right here. Right there. Now, go ahead and adjust. Hit the button that says adjust chamber. Yes. And then push and hold the up button, and you'll hear it click, and this will go up. Bring it all the way up. Because I'm going to show something, and I don't want to suck air in this system. Good. Keep going. Good. Stop there. Hit confirm all. Yes. Perfect. Okay. Now, let's say you're on ECMO and you start to get chatter. So let's watch our flows, and let's watch and see what happens with the CRRT. Right away, you get a return disconnected. And the reason for that is your return pressure became uber negative. And that is why it sees some change. And that is the reason why you get that alarm. Because, of course, you're going to get chatter from up here. Okay, so what if, let's go to the full screen on that. So we're at 3.5. Go ahead and hit continue anytime you see that. So come back here for 1 second. Let's take a look at all the pressures, and I'm at 3.5. Now I'm going to set it up the way I normally have it. So I'm going to set this. I'm going to move this from here. Oh, pause it. Just hit stop. Hit. Okay. As soon as it starts, go ahead and hit stop when it gives you the option. Okay. Okay, hit stop, please. Perfect. Thank you. I'm going to put this back here. Okay. Turn this like this. Okay, resume, please. Continue, resume, yes. Okay, so I'm at 3.5 liters of flow. You see what my circuit pressures are. I've got 94 on P1 or my return, negative 92 on my return on my access, and I'm at 3.4 liters. So go big on that. I'm going to go up to 4 liters. Let's see what effect it has. First of all, it's going to have an effect, should have an effect on every single one of those pressures. So let's see. So I'm going up to 4 liters on my flow. So go back to the big. Now, that's okay. Hit continue. It saw a change, and whenever it sees this change, that's what it's going to do. But you see our return pressure, our access pressure looks good, but our return filter pressure looks good, but our return pressure and our effluent pressure are not as positive as they were because I am generating a higher negative pressure in my ECMO circuit now, negative 130. So that pressure is having an effect on that circuit over here. And that's what you have to take into consideration. So bring it up big again. The other thing is we have a return pressure that is negative, and we do not want that. So in this case, I'm going to do the same thing I did before, only I'm going to increase the amount of resistance. Go ahead, big on that. Oh, too much. It's going to alarm. Ah! Okay, I got it. I saved it. I'm going to increase it a little bit. You got to be very careful. You got to do it very gently. I got a little overconfident there. There you go. Maybe a little too much. Make it a little less. I just opened it a little bit. Let's see. And it's settling down. Now that looks good. Again, your return pressure is positive, and your effluent pump now is going to act as a dam to control the amount of volume that is coming out of the patient, as opposed to pulling the fluid across the filter, across the membrane. That's what I'm trying to elucidate here. Okay, so let's look over here. We're at 4 liters. Now, let's say we want to get more dramatic than that. Let's say we need 5 liters of flow. I'm going to try it. Let's bring up the CRRT. I'm going to go to 5 liters. I want to show the CRRT numbers. I want to show the machine numbers. There you go. So I'm going to do this. Now watch, your access pressure and your return pressure. Your access will go up because it's on the positive side, and your return pressure will go down. 4.5 liters. Just leave it up, just because I want them to see it. They can see it. That's all right. I'm telling them. And I'm at 5 liters. Now at 5 liters, look, the return is already down to 52 and your access is up to 160. So go ahead, and because it sees the return dropping because the pressure started dropping, it'll give you an alarm. You just simply hit continue. But you see that our access pressure in the ECMO is negative 200. Our return is now 182, is now 180, 181, 182. So this is actually greater than 200. But this particular configuration works very nicely because a lot of the pressure gets damped in this recirculation line, and I can manage that. So go ahead and go back to the big screen on that. And I'm going to do the same thing. Don't change it, though, so I can see it. And I'll show them in a second. I'm just going to put a little more resistance on this stopcock, just a teeny little bit more. And try to get my return pressure a little more positive without going too positive, like I just did. Hit continue. Release clamp. There you go. Okay. Let's try it again. Nope. Try it again. And it takes some finagling. No, it's not. Hit can override, please. Thank you. There you go. I'm almost there. Look. Okay, come to this. And I'm just making the teeniest little increments. So go ahead and go back to that. There you go. Return pressure is positive. Effluent pressure is positive. Access pressure is well within limits. And everything is working great. And basically what our system does is you're taking it from the oxygenator with a length of line going to a connector that is turned at, so it's open to all 3 ports, going to the CRRT machine, coming back from the CRRT machine, going into that exact same recirculation line, which naturally flows this direction, measuring your pressure here and going back into your access line, into your centrifugal pump, back out into your oxygenator, and then back there to the patient. And this is at a flow of nearly 5 liters a minute. That's the pressures you should see, and those are the pressures that will work. You won't have a whole bunch of alarms. So let's do this. I'm going to make some other changes. So let's pause that. Yes, stop. And I'm going to turn this off for just a second. Okay. And I'm going to make, oh, sorry. Turn that off. Okay. So we'll make some additional changes. Okay. Get the air out of the simulator system. Normally, we don't have that much air in our system, right? Okay. So I'm going to now take this. And one of the configurations I remember we saw was this. So sorry. Coming from the access, which is here. No, it was here. The access was here, right? And the return, or the access was on the negative side. The return was on the positive side, because that's the craziest thing I've ever seen. So I'm going to put this here. I want to put it right up against it. So I'm going to take this off. I'm going to remove this. Okay. Okay. Not making it easy for me. This I'm going to put here. Okay. This I'm going to put here like that. Okay. And then the return, this is the access. No, this is the return. Gosh, dog, you see what I mean? How I get confused? I'm even confused. It's hard for me. Access is blue. We turned blue blood red. They had this on the positive side. So I'm going to put it here. Okay. Right. No, they had both on the negative side. I told you I'm confused. You're not helping me. You're just sitting there looking at me. You're making me feel really bad. Really, you're making me feel really dumb. Do you remember? Oh, they were both positive. On both of them were on this side. Was that right? Both were on this side. So I'm going to put this here. This is the return. And this is the access. I've got it now. Okay. So now the configuration is, guys, forgive me, man. I'll tell you what, I'm not doing too well today. All right. So we have the blood coming out of the centrifugal pump going before the oxygenator. You have your line here going into your access. And then or your return going there. Your access is here, coming out of the top of the oxygenator, going directly into here, going through the circuit, coming back to also the positive side. Post-oxygenator, pre-oxygenator. I got it. Okay, let's crank her up. No, not yet. Let me get this up first. Let me get this running first. So we're going to go up to 4 liters a minute. That's giving us 127 and 146 at 4 liters. Okay, hit continue. Resume. And let's see what those pressures are. Okay. Look at how high that return pressure is trying to pump into what is the highest pressure point of this entire system. Now, I can't argue the return pressure looks great. The effluent pressure is high, pretty high, and the access pressure is acceptable. But your filter pressure is almost to the point where it will think it's going to clot. So hit continue. Now, let me show you how, one, change your configuration. This is the most appropriate thing to do. But let me show you how you can fix this. Put that back on full screen. Hit adjust. No. Okay. Hit silence and release clamp. Okay. Continue. Confirm. Adjust. Blood flow. Bottom left. 200. Down. Continue. Confirm. Ah, you were too slow. You got to go faster. Do it again. You got to go to blood flow. Blood. Down, 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 down. Confirm. 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 Now, with the lower blood flow, you should have a lower return pressure, which will mean you're going to have a lower effluent pressure, which means you're going to have a lower filter pressure. The filter pressure earlier was about 420. It was about to explode. And so just by reducing that blood flow, you're able to then tease it through. But I do not like this configuration, and this is why I don't like this configuration. So let's go back to the original configuration, because I think that works best, and show you how changing some things over here will affect what you're doing a little bit over here. It really won't affect your blood flow very much unless you are just really pulling a lot. But remember, it's a closed system. What you take goes back in, right? Okay. Okay, go ahead and pause or stop. Okay. Now this has to go back in here. Okay. Well, I'm connecting. Yes, I'm connecting the recirculation that I line that I use back together. That's a good point. Okay. That's a good point. Uh-oh. Well, that wasn't good. Okay. That probably didn't help. We'll have to work on that here in just a second. Okay, that back on. And then I've just filled the circuit full of air. So I'm going to have to get that air out, but that'll be easy for me to do. Okay, so what we'll do is we'll turn this off. You're still off, right? Yes. Okay, so I just have to get rid of that air. Thank God there's no patient attached to this thing, or this patient would be toast. And go ahead and let that air go through. You're not running it, right? No. Okay. There. Back to 4 liters. Okay, that's good. All right. Now, open this. Go ahead and turn it back on. Now, we're hooked back up in our regular configuration that we have with our multi-port stopcocks. Yes, resume, please. And let's see what we have. All right. Give that a second. And where is my blue line? My blue line's still attached here. So we're going to take this off. Put this here. Okay. There you go. All right. There. Okay. All right. There you go. So hit continue. Now we should be back to where we were. You may have to hit release clamp. Just hit continue. There you go. Go ahead and make that big. There, I had to set it back up again. So now we're back to that same situation of, oh, actually, we're just a little bit positive. That's okay. There's nothing wrong with that. You just don't want your effluent to be negative. So 21 is just fine. But remember what I told you earlier. Do we have a high enough TMP? Take a look at the TMP, because the TMP is going to be there whether it's negative or whether it's positive. Right now it's 3. So go ahead and take and do patient fluid removal rate back to 1500 and watch your effluent pressure. Patient fluid adjust. You have to get out of that. Go back to information. Yes. Delay test. Bottom right. Okay, so the machine is doing a test. Okay. Adjust. Patient fluid, to go back to 300 cc's of blood flow. And let's look and see what those pressures are first. Make sure that we haven't messed something up, because you'll have a higher return pressure because you're flowing more, right? Okay, and your effluent's 50. Now turn that back on and turn your patient fluid removal rate to 1500. Adjust. Patient fluid removal. Go to 1500, just push and hold it. Hit confirm. Now let's look at your effluent. Your effluent pressure should come down. Now, let me show you what the difference is. Go to 200 cc's of blood flow. Look at the difference that makes in that effluent pressure just by changing that blood flow. You're barely in the positive range, but you still are positive, so that still is acceptable. However, if simultaneously to that, I come over here and I turn my flow up from 3.8 to 4.4, now look at that pressure. Now your return pressure is negative. Just hit override. Now, leave it right there. I'm going to go up even more on my flow. I'm going to go to 4.6. Okay, now let's look at your effluent pressure. Look at your effluent pressure. Oh, there. Now your effluent pressure is negative. And you're still trying to remove, right? You're still removing? Are you still removing? The effluent pump is turning. The yellow pump is turning? Okay, so now go to replacement. Adjust. Replacement. Turn the replacement on at, 2500. Push and hold. That's good. Confirm all. Good. Oh, go back, adjust. Make all of your replacement post. Go to pre-post on the bottom. Move your arrow till it says post. To 0, go to 0. 0 pre, confirm. Now, let's look at our pressures. Now look at your effluent pressure. Now your effluent pressure, you saw that yellow, go back to the big screen. You see the yellow pump. Is it running? Oh, there it is. Oh, go back to effluent pressure. Turn it back on. Wait, watch it. It's going to go way negative. Patient fluid removal, effluent, okay. Not too bad. Didn't make too much of a difference at all. Not too bad at all. But what happens if I have to come down on my flow sum? So now I'm going to go from 4.48, I'm going to go to 3.5. Now let's see what those pressures look like. Your effluent pressure actually came up. And that is because here we are with our return hooked to this line. This line is both positive, and this line is both positive, and this line is negative, both. So the pressure in this line decreases as you get closer and closer to your actual access line. Right? Okay. And let's put this back on the big screen. Okay, I would say let's go up to 300 cc's of blood. Go to 400 cc's of blood flow. Adjust, blood, 400. How does that look? Those numbers are absolutely perfect. And this, so going back to this configuration really works nicely. Now remember, this is a simulation, so we don't have quite as many connectors. We have one line that comes down, and we have 3 stopcocks. It'll be down in this area. 1, 2, 3, with lines holding them together and then going back into here. We typically do not measure our access and return pressure in our ECMO circuit. We know what it's doing. We don't feel like we need to read the pressure on it. We just find it distracting. However, with that said, that's what it looks like when you actually are measuring. Now, if you have more resistance, anything I do to this circuit will affect it. So if I add resistance and make that pressure more negative, go back, you'll see that those numbers there are going to change. In fact, they changed dramatically. They changed very dramatically by increasing resistance in this line. If, on the other hand, I have more resistance on that's my access. If I increase my return line pressure, you see, that decreases the flow because there's more resistance without more RPMs. This becomes here less negative because there's less flow, and the CRRT machine is going to get affected in how you see it there. Still acceptable numbers. But if I have to now, because I have more resistance to outflow, I come over here and turn this up to try and get those 3.5 liters. You see I'm getting a much higher return pressure, not as dramatic of an access pressure, but let's look at the CRRT. You see there where we drove up all of the pressures. So you understand that everything you do in one place will affect what happens in another place and vice versa. What you do here will affect whatever you do here. So I'm not sure if that was as good a demonstration as I would have liked. I did the very best I could with all the technology that we have and doing this on my own. But Magic, you know what? Take a bow, man. Come on out here. Come here and take a bow. Okay. Magic has never run a CRRT machine in his life or an ECMO machine, and he did an exceptional job. So I want to thank Magic. He's our technical director of the PerfWeb. So this is Maciek Skradalovic, for those of you who don't know who he is. Thank you. I appreciate you, man. Thank you. All right. I think we got to stop the alarms, or if I hear one more alarm today, I'm gonna lose my mind. Okay. All right, there, do that. All right, I want to thank everyone for attending today. I think, are there any questions? Let's see. Greetings from New York, SK, Shiraz Khan. Hey, good to see you, man. So if there are any questions from today, please do not hesitate to reach out to us at our email, contact@perfusioneducation.com. I know that was maybe a little bit discombobulated. It seemed that way to me. It was very challenging to do from one side of the table to the other, and 5 or 6 different cameras and 2 different machines and circuits going everywhere. And maybe I could have planned that out a little bit better. I'm not sure. But I hope I at least showed you that you can connect your CRRT machine to your ECMO circuit and run it at very nice blood pressure, very nice blood flow, and really provide a strong therapeutic modality for therapeutic session for your patients who may need CVVH. Again, I don't like to call it CRRT. I prefer to call it CVVH. But it is what it is. And I highly recommend that you, of course, ultrafiltrate during bypass, that you Z-buff, that you learn more about the various fluids, the bicarb-based fluids in particular, and that we start taking that more into consideration as part of our bypass armamentarium, if you will. So with that said, it has been an absolute pleasure, and I look forward to seeing everyone at PerfWeb 100. If you're not going to already attend the didactic portion of the ECMO course, remember that is included in your if you are an unlimited plan person on perfusion education, that ECMO specialist didactic portion is included for those people. Otherwise, I don't remember the cost. I think the cost is about $600 for the didactic and about $2,800, $3,000 for the full course. But the full course has 30, I can't remember. How many CEUs does it have for perfusion? I think 40, 38 or 40. I don't remember. It's a high number. It's 34 hours total contact hours, including 17 hours of didactic and 17 hours of simulation. And you leave there really understanding how ECMO works. You leave that course very, very empowered and very comfortable managing ECMO patients. We really teach you a lot, and Vicki Carlisle in particular does a great job. So with that said, great effort, Joe, but my preference is trialysis catheter on patient. Too many mishaps on air entrapment on ECMO circuit. Oh my God, air. How do you get air in your circuit? Well, now, if you have no connection points, and you bring up, SK, you bring up such a very good point, and I hate to go belaboring this. I don't mean to get off track, but SK's point is very well founded. If you look up also circuits monitored by, I think you put in the search string somewhere, you will find that also in previous, now they haven't updated this. This is, whenever this was done, it was done, but it's never been updated. So I'm assuming they feel the same way still today. If your ECMO circuit has no points of connection, then it is appropriate for the nurse at the bedside to monitor the ECMO. If there are points of connection, vis-a-vis stopcocks with pigtails or pigtails with stopcocks, whatever, or you modify the circuit in any way, then the recommendation is that it be ECMO specialist or perfusion. And I will tell you, SK, you are 100% correct, because it is not difficult to turn a stopcock the wrong way. I did it today, of course, but I was, I got, that's not clinical, but it could happen clinically too. I mean, there's no question about it, but you got to be very careful, because you absolutely can suck a tremendous amount of air. And if you're on VA ECMO and the patient is ECMO dependent, there's no way to get it out. You're not getting the air out. So very good point. SK, you are correct. CardioHelp does not allow cutting into their circuit. That is true. People do it all the time off label. And but it voids the warranty from McKay, and it protects them in court should there be a mishap. So that's the reason that they do that, and that's a very good point, and it's absolutely correct. So I think it really depends on your comfort level. It depends on what you are used to doing, and what you feel is safe in your practice. But I cannot argue that it is much more safe to have nothing connected to the circuit than it is to have it connected. But I also recognize that trialysis catheters not infrequently have positional issues. There's no real estate in which to put them in. You have yet if they're not already in, you now have to stick a patient who is anticoagulated, and if you backwall it or go through it and you hit an artery, whatever the case may be, you end up with a bleeding patient, and you have all kinds of other problems. Now you can, certainly can't stop your heparin for some period of time so you get the bleeding under control. We do that. That's not unusual, but it's, it is what it is. And, but your point, SK, is well taken, and very good ones. Could I see that again? Oh, okay. Very good. Okay. So with that said, anyone else has any comments or any questions? Again, contact at perfusioneducation.com. And, I'm interested, SK, how many ECMOs y'all are doing. And if you've got a big ECMO program, I'm assuming you're from New York. So I'm guessing you might be at Columbia. I'm not sure. But if you are, man, reach out to me. I would love to pick your brain and get you, maybe, if you would be willing to, online and on air with us, and maybe talk about your experience and some of the reasons why you do what you do. I think that would be very interesting. So thank you very much, everyone. Be safe. Have a nice weekend. I hope your Friday is not too crazy. Nice schedule, but that you can get out early and bug out for the weekend and have a good weekend. I'll see you next time. Peace out.